When you learn a little bit about the procedure, it looks painful. We don't want to obviously scare people away from being donors. That's the primary purpose of this, is to encourage people to become donors and not be scared of things like pain and opioid use afterwards. But it looked uncomfortable, and patients were honestly very uncomfortable in the recovery room. I spoke with Dr. Hudspeth, and she also has a unique perspective because she was actually a bone marrow donor. So she's been through it herself before through the National Marrow Donor Program, through Be the Match. And so she had some perspective to share into what it's like and, what recovery was like. And she's like, if we can do anything to make recovery or hesitancy for donors better, then by all means, let's do it. So what we changed was the way we numbed up basically a patient's back for good pain relief afterwards. So by way of incorporating some other, actually multiple groups of physicians, nursing staff, the nurse coordinator through the oncology or the bone marrow transplant department, we were able to now incorporate this new procedure, which is a regional anesthesia technique, meaning with a teeny tiny needle, we inject some numbing medicine in the low back, and it actually can keep you numb for up to 24 to 36 hours. Some of our patients are even saying 48 hours. It's hard to really confirm that, but basically at least a day of comfort. And so what we saw when we performed this on the first patient, the beginning of January 2020, is that they required no pain medicine in the recovery room, which actually blew us all away. We were confident that it was going to help, but we were blown away by how successful it was. Nowhere had we seen this being done in any sort of research or literature.
Contrast that to what it would be like without this new procedure.
Sure. So the process before was that the proceduralist would put in some numbing medicine, but right where the small incision was. And that's more of called a field block. And in some cases it works great, but it's not as reliable. So we offered for that, we had a great plan, like, let's switch this out. Instead of you doing this, let our anesthesia team do it and see what we get, see what happens. And we had a really fantastic first patient who was very amenable to participating in something new and different, and she was very pleased at the result.
So the spinal block that you're doing now, from a procedural standpoint, how similar is it to like an epidural, which is pretty common?
Good question. And that's actually a little bit of a confusing part. So there's actually two parts. So you can have a spinal, which is a one-time injection in the low back. We often use this for women having C-sections to numb you up enough to have surgery, so that you're comfortable. And actually, a group of patients that we had in our cohort did undergo spinal instead of having a breathing tube placed. So there's kind of two different things, like how to have anesthesia in the OR to have your procedure successfully, and then another type like regional anesthesia, where that's focusing mainly on post-operative, some intra-op, but mostly post-operative pain control. So some patients, yes, they did get a spinal. The difference with an epidural is that's a catheter that stays in. Spinal is just a one-time numbing shot. This regional anesthesia block actually goes on both sides with a small needle in between some muscle layers. It goes nowhere near any major structures like the spinal cord or the spinal nerves, and it numbs up nerves in basically a layer in between two muscle layers, and that's what gives you the prolonged pain control.
That's fascinating. And so you said the first patient you did this on required no opioid pain meds afterwards, which
Correct.
I think is a really fantastic outcome.
Yeah, we were absolutely floored by how successful we were in decreasing the immediate post-operative opioid requirement. What was a little bit harder to tease out was what patients were taking when they went home. And so previously, in talking with the nurse coordinator, Stacy Warnicki, we would see that patients would take narcotics or opioids, most likely oxycodone afterwards, fairly regularly, sometimes requiring an extra prescription refill and sometimes requiring delayed return to work notes, which is really important when you're thinking about the population that's going to be donating. Usually these patients are like productive citizens. They need to get back to work. They need to get back to their lives. And that becomes not only with pain, a huge reason to avoid donating. It's like, how am I going to fit this into my busy lifestyle? And so once we started doing this numbing shot to help with pain control, we were able to prescribe less oxycodone afterwards. We've given no refills, and we've not written any delayed return to work notes. So none, zero.
Wow.
That's really fantastic.
Yeah, it's amazing.
Well, let's talk about that block. I wrote a couple of notes here. The QL block?
Yes.
Can you maybe describe that a little bit
Sure.
to us?
Yes.